welcome to June 9th, 2025, or after, depending on when you're listening to this. But today is a celebration of the book launch Floored by Dr. Sara Reardon. She's also known as the Vagina Whisperer, and I am replaying an episode that we recorded a couple of months ago all about the pelvic floor. So congrats, Sara. I am cheering you on, and I wish you abundant success with your book, Floored. Hey guys, just a reminder, my online course is Birth Story Academy, and you can enroll in it at birthstory.com. It's taught by me. You can be in your jammies. It's online. It's pre-recorded, and it has a ton of freebies and downloads. It's everything that you need to prepare for your hospital birth. So hope to see you in Birth Story Academy. It starts when we are young, when we get our periods. When we first see blood, we feel scared. When the adults around us talk about it in hushed tones, we grow ashamed, as if discussions about our bodies should be hidden. As we get older, we slip tampons up our shirt sleeves when walking into bathrooms and roll used panty liners into toilet paper to hide them in the trash pails. If we have a baby or menopause looms, we start wearing black pants instead of colorful ones in case we leak a little urine. We avoid intimacy with our partners because of pain, or perhaps worse, we silently endure sexual discomfort for fear of letting our partners down. When it comes to down there, hushed conversations have become too much of the norm. Women suffer in silence because our pelvic floors are not the priority in our healthcare system. Floored by Dr. Sara Reardon. Hey guys, it's Heidi, and today I am speaking with Sara, aka the Vagina Whisperer, about her new book, Floored. And today we're talking all about the pelvic floor, pushing, pregnancy, postpartum, sex, and a little bit into perimenopause and periods. Thanks for being here. Let's get to it. What does a contraction feel like? How do I know if I'm in labor? And what does the day of labor look like? Wait, is this normal? Hey, I'm Heidi. My best friends call me Hides. I'm a certified birth doula, host of this podcast, and author of Birth Story, an interactive pregnancy guidebook. I have supported hundreds of women through their labor and deliveries, and I believe every one of them and you deserves a microphone and a stage. So here we are. Listen each week to get answers to these tough questions. Birth Story, where we talk about pregnancy, labor, deliveries, where we tell our stories and share our feelings. And of course, chat about our favorite baby products and motherhood. And because I'm passionate about birth outcomes, you will hear from some of the top experts in labor and delivery. Whether you are pregnant, trying desperately to get pregnant, or you just love a good birth story, I hope you will stick around and be part of this Birth Story family. Hello, Dr. Sara. How are you?
Good, Heidi. Thanks for having me today.
Welcome to the Birth Story podcast. And you guys, as you heard in the opening, Sara is the Vagina Whisperer. I've been a big fan and followed you for many, many years as you pranced around in a vulva costume.
True story.
Yes.
It's still happening.
Yes. And today we're here to talk about your new book, Floored, which is available June 10th, 2025, and all about women's health and pelvic floor therapy at any age and at any stage. So I really appreciate you being here.
Thank you. And the book is available for pre-order now. I'll say that right off the bat, which you can get it and it'll be on your doorstep on June 10th. So I encourage all of you to check it out.
Yes. And no matter when you guys are listening to this, so this is coming out on March 6th, 2025. So if you're listening between March and June, you can pre-order. If you are catching this episode on the June 10th release of this episode or after, then the book is already available for you to go ahead and order, and all of the links are in the show notes. So Ready to dig in, Dr. Sara?
Yes.
Do you like to
Yes.
go by Dr. Sara or just
No,
by Sara?
Sarah is good. I'm like, scratch the doctor.
I know, it's really funny. My sister has a doctorate, and I always call her Dr. Sam. Or
That's
her
so
name's
funny.
Samantha, but Dr. Sam, and she's like, okay, loser, stop it.
I won't say that, but I'm a physical therapist, and I think most of us, the relationship that we have with our patients is not doctor facing. So I think we typically just go by our first name.
Well, in the book Floored, which I got an advance copy of, which was amazing. Thank you so much. The book goes into a very deep dive that all women should read and know and understand their bodies. It is really a great book, Sara, and I learned a lot. I'm hoping this audience will snag a copy of it and like get out the mirror, look at their vulvas, explore their labias, find out where your urethra and your clitoris are. I mean, these things are really important. The deep dive is in the book. You guys, we're going to go like a high level overview today in this podcast episode, but hopefully you learn a lot. So this is a pregnancy and birth podcast. You will learn all about menopause, your period, from start to finish in the book. But today we're going to focus a little bit more on pregnancy and birth in the postpartum period. And so, Sara, I thought I would open it with my own personal story.
Let's go.
I was a person who did not know what her vagina looked like. How often do you see that in your practice when people come in and you have a mirror and you're like, have you ever looked at your vagina? Have most people looked at their vaginas?
No, I would say out of 1,000 patients, 999 have not looked at their vulva and vagina.
That makes me feel so much better because I had seen everyone else's vaginas. Like so familiar with all the different vaginas. And then I found myself in pelvic floor therapy holding a mirror in my hand. And I was like, what do you want me to do with this thing? You know?
I know. It's interesting because I think that, we in pelvic floor therapy, and I go over this in the book as well, is that we train folks how to relax their pelvic floor muscles, how to contract their pelvic floor muscles, how to push and bear down if they're planning for a vaginal birth or even just having a bowel movement. And, it helps to be able to see what your muscles are doing, which you can look at when you have a mirror looking at the vulva and vagina and the perineum. And, but most people haven't seen it, but the very few people who have, they often look when something's wrong. They look like after giving birth and they're like, whoa, what is happening down there? Or if they feel like a bulge at the opening of the vagina, or if they feel like burning or irritation or pain with sex. And that's when they look. And I said, it's really important for you to know what your normal is so that you know what your like abnormal is. And then you're better able to identify when something is off. And so, as a pelvic floor PT, the courses we go to, we're the patient and the practitioner. So when I'm doing pelvic exams on other folks to assess their muscles, somebody's done that on me before. So I think it really helps the practitioner, myself, get comfortable with my body, understand my body. And that really helps us to better educate our patients. And also just, I think is really, we have a lot of empathy for the experience because we've been in that position before. So yeah, in the book, I kind of go through like, okay, step one, you got to know what's going on down there. And I don't say that to kind of like weird people out, but it's really a body part like an elbow or a knee. And I think if we really start looking at it from a very physiological and anatomical way, it kind of just takes it demystifies it a little bit. And then we're able to just have more open conversations.
Yeah. In the beginning of the book, you talk about like hiding the tampon up our shirt sleeve and kind of like this quiet hush hush culture that we've grown up in, like not talking about our vaginas and how they work and what they do. And that really hit home because there I was in pelvic floor therapy getting ready to have a baby and not really even understanding what my own anatomy looked like. And I was a doula. I should have totally known that. So the first thing I wanted to ask you for the audience is like, what is the difference? Because this one gets me every time between the vulva and vagina.
Absolutely. So when you think of your pelvis, you think of those bones, those skeleton bones that you see. And at the very base of those bones is a basket of muscles. And that's what we call your pelvic floor muscles. And they kind of sit like a hammock and they attach from the front, the pubic bone, the back, tailbone, and side to side. And that basket of muscles has 3 openings, one for the urethra, which carries urine, one for the vagina, which is a muscular tube that connects the outside of the vulva to the cervix of the uterus. And then the last opening is for the anal opening for poop. So the vagina is actually an internal canal that is just a passageway for menstrual blood, for vaginal birth, for vaginal intercourse. The vulva is everything outside of that, which includes the labia, 2 sets of labia. You've got the labia majora, which has hair, the labia minora, which is the inner labia that's hairless, the clitoris, which is the sex organ, the mons pubis, which has hair. So kind of everything on the outside is the vulva. Everything internally is the vagina.
Thank you.
Yeah, it's important for folks to know because, you know, when we talk about different parts of our body, we're like, oh, my vagina hurts. You might be talking about your vulva and vice versa. So it's one of those things that, again, just like the basic anatomy. I mean, I'm 42, have been in this field for 18 years, and I don't ever remember learning about that until I was in my mid-20s in physical therapy school. But yet we had sex ed, and I've been sexually active, and I've been to the gynecologist, yet we don't even know the difference in our body parts. So it's kind of like a 101 that we really start from the beginning.
Yeah, I'm going to jump around here a lot, Sara. So I am recently back in pelvic floor therapy now at 46 years old. I'm 46 years old. I was like, how old am I? And again, I found myself with a mirror. So here I am with a mirror like 10 years ago, like giving birth to my children. And here I am kind of in perimenopause with a mirror again. And I had just watched an Instagram reel that you had done that I thought, she's full of shit. There is no way. And you were talking about how the labia minora goes away in menopause where like the tissue changes, you know, shrinks. And so I'm in pelvic floor therapy. Her name's Dr. Q. And I said, give me that mirror. I need you to tell me if my labia minora is still there or not. So I'm going to go back to this, but this is real, right?
Yeah,
like,
okay, it's totally real.
So let's talk about what changes, like when you're, let's start there. So when we are like going through puberty and then all the way through to menopause, what are the changes that we see in the vulva?
So, you know, the vulva and vagina have receptors that are, that bind estrogen. So we know estrogen is a hormone in our body. The role it plays in the pelvic floor is that it lubricates the tissue. It creates lubrication. So natural moisture in the area, lubrication with arousal during sexual activity. It also plumps up the tissue and makes it thicker. So it helps support those walls to make them more supportive of your pelvic organs, to give your vagina more tone. And what happens is every month within our period, we have cycles where estrogen increases right around ovulation. This is when we get that like goopy discharge that looks like egg whites, and then it decreases and it becomes a more clumpy discharge. And then there's a little spike again right before we have our period. So that cycle kind of helps us understand why we have different types of lubrication and cervical discharge. Also, why we have different libidos throughout our monthly cycle. Like we have higher sex drives when we have higher estrogen and higher testosterone. And then where our vagina might be a little bit drier at certain times in our cycle. Like if you put in a dry tampon, it feels like really scratchy and itchy, or sex, maybe you need more lubricant or something like that. It also influences your pelvic floor tone. So you may find during certain times in your cycle when your estrogen levels are lower, you're like, I just feel like I can't have a good run today, or I feel like I can't lift weights. And I was like pumping it out at the gym the other day. Like you'll just feel differences in your body. And that happens every single month. During pregnancy, you have another humongous surge of estrogen. You have like 30 times more estrogen during pregnancy. And that's why you have all of this goopy discharge coming out of your vagina. This is why some people have a higher sex drive. And then postpartum, your estrogen plummets. And the reason it plummets after giving birth is because the hormone that produces breast milk surges and estrogen declines. So they work opposite. So when you're making breast milk, you have really low estrogen, and that's why you don't have a period for a long time. And so that causes weaker pelvic floor muscles, more vaginal dryness. And that's another time that we see the labia start to resorb or the vaginal tissue start to break down or get weaker. And then when you get further away from postpartum, things start to rejuvenate, your period comes back, you go back to the monthly cycles. But then when you enter perimenopause, your estrogen starts to decline again. And that's like a gradual decline. But once you hit menopause, you have like no estrogen stores left. And this is why we see it externally with hair thinning, with skin changes on our face, but we also see it in our vaginas. And I will so often have women come in and they're like, sex is painful. I don't know what's happening. All of a sudden, sex is painful. And I'll look at their vulva and vagina or look at their vulva and I'm like, their tissues are really dry. It's like their underwear sticks to their tissue, their labia sticks together. They have itchiness, redness. It could look white and patchy and their labia start to resorb because they don't have enough estrogen in their bodies to help keep those tissues plump. So that's, it makes it feel like the life cycle of a woman is like so difficult and challenging. I really think what the challenge is that we haven't been supported. We're going through these monthly fluctuations and then long-term changes in our bodies when we hit perimenopause and menopause. And there's no support. It's kind of like, oh, this is just the natural course, deal with it. But I'm like, no, there's a lot of things you can do. Hormones, pelvic floor therapy, exercise, that can all be helpful to make these changes more manageable.
Yeah, the way that you said that, I think, was really beautiful about like it all kind of ties back to like hormones and specifically estrogen. I have heard it described probably by you as breastfeeding is like a mini menopause when it comes to like vaginal dryness and changes in the tissues. So this is where we're going to get into how taking care of your pelvic floor in your pregnancy and in your postpartum, even preparing your pelvic floor if you're a TTC or trying to conceive, and how important that is. Our pelvic floor is something that has been ignored, and we are here today listening to this podcast because it should not be continued to be ignored. So I'm a birth doula and I host this podcast, and all these people come to me for advice. So what is the advice for pelvic floor therapy in pregnancy? Like, do you just get through your pregnancy and then go to pelvic floor therapy if you have a problem? Should we be doing pelvic floor therapy proactively?
Absolutely, you should be doing pelvic floor therapy proactively. I mean, your pelvic floor muscles stretch just during pregnancy itself. And I always make the analogy of, we get these weekly text messages or app updates that are like, your baby's the size of a lime, then it's the size of a papaya, then by, 38 to 40 weeks, it's the size of a watermelon. Well, if you think of your pelvic floor as that hammock of muscles supporting your uterus and growing fetus, if you have a hammock with a lime in it, it's not going to change that much, right? But if you have a hammock supporting a watermelon, that hammock is going to stretch, it's going to sink down, it's going to be weaker. And that's ultimately what happens to your pelvic floor during pregnancy. And this is why pregnant women experience back pain, hip pain, core weakness, urinary leakage, pelvic organ prolapse. And it's always been kind of just dismissed like, oh, well, this is just pregnancy. But if we know that pregnancy affects the pelvic floor, regardless of what method of birth you have, cesarean or vaginal, why aren't we supporting women and to manage that? Why aren't we giving them exercises to decrease leakage, to give them more pelvic organ support, to reduce back pain? So I absolutely recommend doing workouts during pregnancy. I have an entire online fitness platform with a pregnancy program that just teaches you how to engage your pelvic floor, to how to activate your deep core muscles to minimize abdominal separation, and to work on your pelvic floor during pregnancy. And then when you get to third trimester, to work on relaxation of your pelvic floor. I think we talk so much about strengthening, but during the third trimester, I really focus on relaxing the pelvic floor, learning how to push, doing some hip openers. We tend to have a lot of tension in our lives, but when you're giving birth, it's a lot about letting go. And kind of, we want the pelvic floor muscles to relax and get out of the way during a vaginal birth versus be tight and strong and push the baby out. And I always say this, like, your uterus pushes the baby out, not your pelvic floor. We want your pelvic floor to be relaxed. But we have to teach folks how to do that. And we can't just expect them to know how to do it when they're in the delivery room. So that's kind of a lot of what you can do during pregnancy to feel really empowered and informed going into that experience.
Yeah. So, Sara, my cesarean rate is very low. I've been to over 1,000 births. Last year it was 2.5%. Year after year, it's 7 to 10%. And one of the key things when people say, "Hey Heidi, how is your cesarean rate so low? What are your clients doing that's different?" Because I would love to say that it's just me, by their side, but it's their body that's doing it. But pelvic floor therapy, and there's a couple of other things with like chiropractic care is another thing that I recommend for my clients, going to acupuncture, continuing to work out.
I'm a big fan of acupuncture.
Yeah. And so many of my clients, you are actually linked in my welcome letter for the V-Hive, which is the online course. And many of my clients have gone through your program. They go to our local pelvic floor therapist because I tell them, if you're going to go to the gym and work out, why are you working out your biceps and your quads and your calves, but not working out your pelvic floor muscles? These are the most important muscles to be, working on when you are pregnant. I did not take my own advice though, Sara, and my babies were very big, almost 11 pounds, my first one. I'm 5'4". I'm not a very big person. I gestated all the way to 43 weeks and I had, significant perineal tearing and a grade 4 bladder prolapse. So immediately I went into surgery because they said, we just don't think pelvic floor therapy is what we do first. We think we do the surgery to put your bladder back into place first. And then, you follow up with pelvic floor therapy afterwards. And I'm telling this story, and the reason that I talk so passionately about pelvic floor therapy is because of my learned experience. I don't want it. You don't have to have 10-pound, 11-pound babies to have trauma to your pelvic floor. I would venture to say all birth, no matter if it's vaginal or cesarean, has the potential to be traumatic to your pelvic floor, and strengthening it is so important. So we went through, it is important to go to pelvic floor therapy in pregnancy. But the second question I get from my clients is, how many sessions, Heidi? How often? And I would love for you to answer that for people that are on a budget, especially.
Right. Well, and I think it varies. So I would say in my clinic where I work here in New Orleans, we have a kind of a childbirth prep experience where you come in for 3 sessions. They absolutely need to be, I would say before 36 weeks of pregnancy. Sometimes we'll get somebody at 37 weeks. It's like, I'm giving birth. I need to train. I'm like, well, we're at the tail end of that, but we will do what we can. But I would say plan for 3 to 4 sessions during pregnancy. And a lot of it is education. We're teaching you how to prevent symptoms, prevent how to breathe, how to engage your core, how to get out of bed, how to lift. I mean, just day-to-day things that you're doing that need to be modified to minimize the risk of pelvic floor and abdominal weakness. And then we're going to work on strengthening if you need it, but then we'll also work on relaxation. And as you mentioned earlier, getting out the mirror, teaching you how to push, going through different things to help with labor. Even if you're planning to have a cesarean birth, what can you do to prepare your body, not just for birth, but also for postpartum? At 6 weeks after giving birth, your pelvic floor muscles are working at 50% capacity. And that's when most people are clear to go back to sex or go back to the gym and work out. But we haven't trained them. So we're sending people back into their day-to-day lives without giving them any education on how to rehab, how to strengthen. So a lot of what I do during those sessions is, go through strengthening, relaxation, birth preparation, pushing. We have partners come in so they can also help coach you. We have doulas come in to also show them what we're doing and how to, because everybody's pelvic floor is different and everybody's hips are different. And then we also go through some postpartum recovery in one of those sessions. So what should you expect those first couple weeks? How do you take your first poo? How do you urinate if you can't start your bladder? How do you pick up your baby? Stretches to do if you've had a C-section. Really helping you feel prepared. And I always compare it to running a race. Like, you don't go run a marathon and never have run a mile. So we're really training you and educating you and your body, teaching your body how to do this physical feat, and then how do you recover afterwards. And then we recommend that you come back in between 4 to 6 weeks, postpartum for a check-in. Some people are great and they can go on their way after that. And some people need a couple more sessions for a tune-up. So that's what in-person looks like. Again, I go through a lot of this in my online platform because one, not everybody has access to pelvic floor therapy in their town. Two, it can be costly. A lot of us don't take insurance, or it can be difficult to get in. There's long wait lists, or it's even hard just to get time off of work or get childcare to access this service. So we really want to find a way to meet people where they are, whether it's virtual consults, in-person consults, online programs. How do we get this information to women so that they can have a menu of options to help kind of meet their needs?
Yeah, I do think there is a combination between of benefit of doing things online and at home. Everyone says to me, "Hey, Heidi, in the postpartum period, how many sessions do you think I'm going to need?" And I'm like, oh my gosh, that's so individualized to,
Yes.
your specific pelvic floor and what type of birth you have and what you have, going on. But I do think, especially for my sexual assault survivors, if they can find a pelvic floor therapist that is safe for them, I do think that an internal exam where, someone like Sara is literally feeling the muscle contraction and the strength, and if you're breathing properly, then you go home and do it at home, become part of a program like the V Hive. But if you don't implement these things at home, I've found from my personal experience, everything just goes right back.
Yeah. And it's so tricky because I know that we all want answers. Like, people want to read the book and they're like, will this help my urinary incontinence? And I say this very clearly, like, you might still leak, you might still have pain, but our goal is to really help you understand your body and give you the tools to help manage it. So when you go to therapy, the good thing about pelvic floor therapy is it's not, 3 times a week for 6 weeks. It's once a week or once every other week for a couple of sessions. And we give you a lot to work on at home because we want to empower you. We want to help you recognize that, like, you have the tools to work on some of this at home, and we're really your guides. Nothing will ever take the place of in-person therapy. But again, there's, 40,000 women out there who might be giving birth, and there's probably 400 pelvic floor PTs, and so I think we just want to have options for people, and it's baby steps. I have people who, like, I didn't get back into pelvic floor therapy until 18 months after my second kid. I was just drowning in motherhood. And I tell people that because I'm like, we're here when you need us, and it's okay if it's not the right time, but when you get to the point where you feel like, okay, I'm ready, like, then you go. But if you're feeling overwhelmed or any of those things, like, it's going to be there for you. But I will say, once people start coming, nobody ever says, I wish I would have done this later. Everybody says, I wish I would have done this sooner.
Right. And I think it's about developing a habit because, like the title of your book, Floored, talking about every age and every stage, it's so true that it comes back, right? Like, I have gone through all of these stages, and now as I'm like kind of like standing on the edge of the cliff of menopause, and I think that if I had helped this to become a habit, right, I wouldn't be facing some of the problems that I have today. So I wanted to give you a better picture too, Sara. Like, the reason it's so important, you guys, to go to pelvic floor therapy before, during, after, but then practice these things as a habit for your lifetime, because like any muscle, if you don't use it, you lose it. And I have found that. So my marriage ended, Sara, 6 years ago. And,
I'm so sorry.
Oh, no, listen, don't be. It's fine.
Okay. Well, then I'm happy for you.
Listen, we're good 6 years later. But, for most of us that are divorced or separated, I mean, I can't speak for everyone, but I would say, like, there's a rapid decline in the amount of sex, intimacy, working out, and then you're aging and estrogen's going down and all of that. So I was hoping this isn't about divorce. This is about pregnancy. And what I see in pregnancy is this parallel to divorce, this like lack of sex and lack of using those muscles. So I was hoping you could talk about pelvic floor and penetration. Like you said, all of the ways in which the vagina is used for, but like the importance of an orgasm with penetration, with muscle contractions in pregnancy and in postpartum. And if people are too afraid to have sex, if you have any like alternative options to make sure that we keep the pelvic floor strong. And I didn't finish my story, but I meant to say that here I am in pelvic floor therapy because my bladder prolapse is back. And I'm like, how in the world did it come back? They sewed it back up there. And I was in the shower recently and I felt this bulge and I knew what it was. And then I went in and found out it was also a grade 1 uterine and a grade 1 rectal. And I was like, well, crap, everything is decided. I decided to not use my vagina. So then all my organs decided to take over my vagina.
I know. And it sounds scary, you know, and I think that your story might encourage people to get their butts to therapy.
Yes.
And so, but your points are so great, Heidi, because 30% of women who have a surgery for pelvic organ prolapse will have a repeat surgery. And the reason I share that is because if you don't get to the root of what caused some of the problems, for you, it was birth, but it could be exacerbated by how you're breathing, by your muscle strength. Now in perimenopause, there's a decline of muscle tone and tension. So, and sometimes there's a genetic factor. If you have a family member who had prolapse, if you have a connective tissue disorder like Ehlers-Danlos, I mean, there's so many factors. All that to say is you want to be really proactive about your health. I mean, I think of it like brushing your teeth, right? We brush our teeth every day, a couple times a day. We floss. If we have a cavity, we get it fixed. And then we keep going into the dentist to get tune-ups and make sure everything's good. It's like, why are we doing that for our pelvic floor? Like, we have one of them. It goes through stages of life like pregnancy, postpartum, and menopause, which are 3 risk factors for developing pelvic floor dysfunction. So we have to help better support women through those. When it comes to sex, it's actually really interesting because I was thinking about different concepts for the book. I am super passionate about pregnancy and birth because I see so many women who are just unprepared. And afterwards, I feel like they're trying to recoup what they wish they would have done earlier, but it's not their fault. It's the medical system didn't provide them the resources, right? But when I started thinking about writing a book about this, about pregnancy and birth, I was like, but you have to have sex for most people to get pregnant, and you have to have a period in order to get pregnant. And so there were all of these other stages in a woman's life where it was so important for them to understand the pelvic floor before even just getting to pregnancy and birth. And so many people have pelvic floor issues and they've never given birth. So I wanted to make sure that there was kind of this really wide conversation about the pelvic floor through all of these different stages. When it comes to sex, the vaginal opening is a ring of muscles. So when someone tries to have intercourse, vaginal intercourse, if they feel like they're trying to put something in the vagina, whether it's a penis, a dildo, a toy, a finger, prior to that, just medically, a speculum or a tampon, if they can't enter something into the vagina, that is typically a pelvic muscle issue. It's like those muscles on the outside are closed, they're shut down, and they're not allowing something to insert. And what happens is that our body starts to tense up because we're anticipating pain the next time we reattempt that. And then you get in this cycle of, pelvic floor tension, attempts at intercourse, it causes pain, then our muscles tense up even more, and you can develop pelvic floor chronic pain and dysfunction because of that. So, one, you've got to have pelvic floor muscle relaxation to have sex. You've got to have good lubrication and blood flow, which helps, comfort. An orgasm is actually a pelvic floor muscle contraction. So your outside pelvic floor muscles are contracting and relaxing. That's function of your pelvic floor. And we don't correlate all of these sexual experiences to muscles. So people will come into my clinic and they feel broken. They feel like something's wrong with them. They feel like they're failing their marriage. They feel like less of a woman because they're like, my vagina doesn't work. I'm like, well, you've never been taught how to use it. And that's not your fault, right? So a brochure in a doctor's office or one lecture in sex ed in high school, just isn't going to cut it for a lot of folks. So it's really about educating them how their body works, teaching them to relax their pelvic floor muscles. We use these different devices called vaginal dilators that look like tampons of different sizes. and coach women on how to insert them, how to relax their pelvic floor muscles, how to use them in different positions, how to use them in different sizes to work up to the size of their partner or their dildo so that they can get comfortable having vaginal penetration, but also to enjoy it. You know, I mean, I think that everybody deserves pleasurable sex. It shouldn't even just be something tolerated. And after birth, we see a lot of women experience pain as well because of perineal scar tissue, cesarean scar tissue, vaginal dryness, or muscle tension. So, you know, just these different cycles we see in life where pelvic pain or painful sex can exist. And yet we want to help coach women through that. It's just like getting an ankle sprain, you know, PT can help.
Yeah. And I just wanted to like echo what you said is that I really get sad when I'm working with when you're somebody's doula, you guys, it's just such an intimate relationship. And so even months later, my clients will call me back and say like, and they're in tears and they're like, I just feel so disconnected from my partner because I'm just so afraid after everything I went through with birth. Just that first time back even is can be difficult. But I think seeing a pelvic floor therapist, reading Floored, getting to know your pelvic floor, it can help you with just these little tips, right?
Yeah.
Of what Sara was saying, like with lubrication and with dilation, like so that you don't have to have urinary leakage or pain during sex. So I just think we need to like continue to keep having these conversations. Now, what I heard during that that last thing that you said was about how connected the mind is. Like you said, like you're fearing the pain, which I think is the brain. And I know a lot of people that will say, oh, I have to have a glass of wine or I have to have like a drink before I could have sex. And so could you just talk a little bit about how the pelvic floor and the mind are connected? And then also that brings in breath and how connected like breath, brain, pelvic floor, and how those are all tied together.
It's so interesting because, you know, we talk a lot about strengthening the pelvic floor, but I think just as important is relaxation of the pelvic floor. And we need to have pelvic floor relaxation for sexual intercourse, for vaginal birth, for day-to-day things like peeing and pooping. And so, but what happens in our daily lives, one, after giving birth, when you're a mom, when you work, just living in the modern world, is we get tension in our bodies. I know I get a lot of tension in my neck and shoulders, and I get really bad headaches, and then it can lead to migraines. It's the same thing that can happen in your pelvic floor. You get tension in the area, and then you have a hard time relaxing it. And then the pace of our lives and the inactivity, sometimes prolonged sitting, being stressed out. You know, I have a really kind of overly sensitive system where if there's like a lot of noise or it's like I just feel overstimulated really easily now that I'm a mom. And this is 10 years in. I can walk into a room and there's my husband's playing guitar, my kids are screaming, the TV's on, there's music playing, and I'm like, my nervous system is just through the roof. Well, your vagina can't relax when your nervous system is through the roof. It's a muscle. So muscles respond to kind of the nervous system activity. So something as simple as taking big, deep breaths really quiets your nervous system. Like if you have an Apple Watch, I'll just kind of peek at my heart rate sometimes. And then I'll coach myself to take these huge, deep breaths, like inhaling for 5 seconds and then slowly exhaling for 5 seconds. And then watching my heart rate come down because my body is physiologically responding to just breathing, to just quieting my nervous system. When you breathe, your diaphragm, which sits at the top of your abdomen, and your pelvic floor muscles, which sits at the bottom, when you breathe, your diaphragm also kind of moves your pelvic floor. So when you inhale, your pelvic floor can like relax down, and then you exhale and it kind of springs back to its normal. So just breathing helps relax your pelvic floor. And this is where it gets a little tricky when it comes to birth. We're coaching women a lot in hospital systems to hold their breath when they're trying to birth a baby. And holding your breath like locks your pelvic floor. When we want mobility, we want softness, we want movement. So, you know, I think that just working on breathing, doing yoga, acupuncture, meditation, walking, therapy. I mean, there's so many different avenues you can have to decompress your nervous system that will also help coach your pelvic floor to relax. And the one thing I'll say about this is that, you know, often when we train them to use vaginal dilators at home in physical therapy, I'm like, don't have Game of Thrones on in the background and like your kids in the room and the lights on. Like, you need to set an environment where your nervous system can be cool, like calm and chill. Do some stretching and breathing, and then do your dilators, or then try sex. And I think that that's a component that we really need to integrate into body work, is also mind work, because they are just so connected. And again, if you have friction in your marriage, if your nervous system's on overload, if you haven't slept, if you're leaking milk, like, it's really hard to relax your body to have sexual activity after birth when all of those things are happening kind of in an outside arena.
Yeah, it's just so interesting. I mean, clearly we know the like people talk about like the brain gut connection and how important yoga and breath work is, but really learning about how someone, it was probably you again, but like put a picture of our vocal cords and how it really like visually from an anatomy perspective, like your vocal cords and your pelvic floor look very similar to one another.
Yeah.
And so that brings me to when I'm watching my doula clients, they hire me like usually on their fertility journey or right after they've conceived. And I am with them for their entire pregnancy and postpartum. And I see their breathing change. They go from breathing being something they don't think about, non-pregnant. And then all of a sudden the baby's growing. And they come over to my studio and I'm watching them breathe now from their chest instead of from their belly. And then they give birth, and sometimes I see them afterwards and the stress of new motherhood, and they're still breathing with their shoulders in their chest. So could you just share a little bit about what I've learned in my own pelvic floor therapy is like the different types of breath, and kind of the people at home listening right now, like maybe even a little exercise that they could do to teach them how they are breathing, or recognize if they're breathing from their chest or breathing from their belly.
Absolutely. And I love the point that you brought this up. And it's very normal for that to happen during pregnancy. You know, we see all of our rib cages kind of open up and expand during pregnancy to accommodate a growing baby. What happens is that you can't take as big of a breath during pregnancy because your diaphragm doesn't have anywhere to go. So your diaphragm is that muscle that sits underneath the ribs. And when you're trying to breathe in, the diaphragm wants to kind of push down and contract, but because the baby's there, it's hard to do that. So what happens is you start breathing with your chest to open up the ribs, right? And even after birth, I mean, we see women with these really wide ribs because they haven't kind of retrained their core to go back down. So one of the ways I coach folks how to get a better diaphragmatic breath, and it's important because when you breathe with your diaphragm, that's what helps your pelvic floor muscles relax. When you're breathing with your chest, everything in your lower body stays locked up, and we don't get that mobility and that relaxation and contraction. So if you're listening to this, I tell people to kind of stand up straight or to sit up straight, nice and tall. You don't have to arch your back. I just want everything kind of stacked in alignment. So no slouching. And then you put your hands on your ribs. So you feel those little bones underneath your hands.
I'm doing it with you guys.
And when you breathe in, I want you to think about breathing into your hands that are resting on your ribs. And you think about it like your ribs are going to open up like an umbrella. So you're going to inhale. And you feel your ribs kind of pushing into your hands, opening up like an umbrella from the sides, and then you exhale all the way out. And you do that again. Inhale, kind of open up your ribs. Your hands are there to kind of give your breath a place to go, right? You want to guide them towards your hands to open up the ribs, not the chest, and then exhale and let it go. And then I also have you do that front to back. You can put a hand on the front, like just underneath your sternum, and even the back part of your hand on your back. And you're going to breathe front to back into your ribs, same way. And you're going to find like, oh, that's kind of harder to do front to back, but the whole complex, the whole rib complex has to open up like an umbrella. And when you just focus on those breaths, that's when I'm like, watch your heart rate, right? Think about how well you can inhale and exhale. I even have sometimes people take like a little scarf or a TheraBand and tie it around their ribs and think about breathing into that scarf or band, because it gives them something to work against. And that's how you're going to get more of that mobility back into your diaphragm to help relax your pelvic floor. So just really simple. And just that helps your pelvic floor relax. And so that's a simple exercise. You don't have to go to the gym. You don't have to go to a therapist, but that really helps the nervous system, helps the brain, and helps the pelvic floor.
Yeah. I did not realize how much your breathing can change in pregnancy and then linger, and really you've spent 9 or 10 months and your brain has reprogrammed the way that your breath work takes over. And it is so important to retrain our brain and our body to breathe in a way that protects our pelvic floor. So I want to move to urination. And pregnancy just has this way of making people feel like they have to pee all the time. They're confused on whether or not they should go to a urologist. Clearly, leakage can become like when you sneeze or cough or laugh. And I read in your book, in Floored, it said 70% of menopausal women wake up frequently to pee. And then I thought, well, I'm confused because in pregnancy, we have a surge of estrogen and we're peeing frequently and having leakage. And then in menopause, we have this decline to zero of estrogen and we're waking up frequently to pee. And I was not connecting the dots, right? Like, why the frequent urination and how does pelvic floor therapy support that in both phases of life?
And that's such a great parallel, and they happen for different reasons. So during pregnancy, there is more pressure on the bladder. So you think of this, that watermelon that's kind of growing baby, and it's putting pressure right on your bladder, and that's causing you to feel like you have more frequent urges to pee. And that can also contribute to leakage. You have less pelvic floor muscle strength during pregnancy because everything is stretched out and lengthened, and you can't close that sphincter as well. When you close your urinary sphincter, like do what we consider a Kegel contraction, it communicates to the brain of, hey, bladder, chill out, because I have to pee, but I'm not ready yet. So doing a pelvic floor contraction or a Kegel tells the brain and bladder to chill and not be so urgent. When you don't have that same contraction during pregnancy, it can't communicate that to the brain and the bladder to hold the urge. And then the last thing is that you have more fluid in your body, right? So you just have a ton more blood flow. Blood flow is filtered to create urine. And then so you've just got a higher urine volume going through your body. So during pregnancy, those are the common reasons that you have more frequency and or leakage. But what happens is that after giving birth, you are in the habit of going to the bathroom all the time. You go every 30 minutes. You go every time you pass the bathroom. You go every hour. You go every time you wake up at night to breastfeed. And so your bladder doesn't ever get back to that full capacity of stretching. And then you don't ever rehab your pelvic floor to tell the bladder to kind of chill out. So we see a lot of pelvic or urinary issues kind of develop during pregnancy and then persist postpartum because we never retrain the bladder and pelvic floor. What happens during menopause is that your estrogen levels, always back to estrogen, your estrogen levels decline. And when your estrogen levels decline during perimenopause and menopause is you have a different pH in the vulva and vagina and urinary tract that it makes you feel like you have more urinary irritation. So you might feel burning during urination. You might have more frequent urges to pee. You feel like you empty, but you have to go again really quickly. That has a lot more to do with the hormonal changes that are affecting the tissues. And also you additionally have less pelvic floor muscle tone. So that tone isn't there to kind of contract the muscles to tell the bladder to chill out as well. So what happens during menopause is you go to the bathroom all the time because you don't want to leak. And then because you're emptying so frequently, your bladder shrinks and then you have to go more often. And you may also be taking medications that have a diuretic effect that makes you go more frequently. So it's much more hormonal during menopause. You start waking more at night, things like that. And those are some of the early signs of perimenopause, like, oh, I never used to have to wake tonight to pee, and now I wake up every night. Or, I used to be able to make it to the bathroom in time, and now I feel like if I don't get there, I'm going to pee my pants. I used to be able to cough and sneeze without leaking, and now I don't. So it's one of those things where you start to see those changes gradually in perimenopause. And then once you're in menopause and you have no estrogen, no testosterone, declining collagen, you're like, well, shit, now I'm in for it. And that's why working your pelvic floor out during perimenopause is so important.
I was going to say, I really appreciate you clarifying those two things. But again, you guys, there are solutions. Pelvic floor therapy is a solution. And we've been taught our whole lives that this is something that there is no solution and that you just have to deal with, and you do not have to deal with that. And then there's so many more tips in Floored. Like I said, this is the high level overview, you guys, but if you really want to dive deep with Sara, we're going to have you get a copy of Floored.
So one of the things I'll tell you too, if you are like, well, Floored's not coming out for a couple months. If you order Floored now, pre-order, you get 30 days of free access to my VHIVE workouts. So you can start them now, no matter where in your pelvic floor journey you are. And I also give you my top 10 tips, which are in my book, but you can get a sneak peek of what I do for my pelvic floor daily, like the different, how I pee, how I poop, the exercises I do, lubricants. So just kind of some things to kind of really start your journey on taking care of your own pelvic floor now. So even though the book doesn't come out for a bit, you can get all of that access now if you pre-order.
Okay. And I am in a book club for pre-ordering. Can you tell about that?
Yeah, so I'm really excited about this because, what I think people really want, so say you don't go see a pelvic floor therapist, is they want to talk about their pelvic floor. I feel like everywhere I go, people are like, let me tell you about this, and so, which I love that we're having these conversations. So, afterwards we're going to have, I think it's going to be 3 different book club meetings where we're going to go through different chapters in the book. We're going to talk about it virtually. You can meet other people. You can ask questions. You can ask anonymous questions. I just really want to be available to people to talk about these things that they don't know where to get help, or they feel too embarrassed, or they just want to learn more and really start the conversations that, even if you're like, oh, I'm not having babies anymore, like you might have children, or you might have a parent, you might have somebody else in your life that can benefit from these tips and tools. So I'm just really excited to share it with everyone.
Yeah, I'm excited to be in book club also. All right, Sara, I'm going to move into the last question, but I think almost the most important question. And this came from my large Facebook community of private doula clients through the years. And they want to know about push prep. So what we can do, since 72% of women birthing in the United States are utilizing an epidural. And I would say that percentage is a little bit lower if you have a doula. My statistics last year were 45%. A lot of people hire a doula that are still planned epidurals. But I am guilty of teaching clients to hold their breath when they have an epidural and push. And I've talked about this with my own pelvic floor therapist. And it's because when my clients don't feel the fetal ejection reflex, I find that they really are not pushed. They're pushing, but not with power to the vagina, to the vulva, to the pelvic floor. And so let's talk a little bit about push prep. What are your best tips for how to prepare to push? I would say like with an epidural, because without an epidural, you just push. I mean, I had an unmedicated birth. It just happened. I didn't feel like I had much control over it.
Right.
Yeah, I'd love to know your thoughts.
One of the things with an epidural, and the research is very, mixed on this, that I tell people to keep it low. I mean, you don't want to feel quote unquote pain, but you do want to feel your contractions. Otherwise, you don't have a physical cue as to when you should be pushing. So spontaneous pushing, which can go along with contractions, is going to give you better outcomes and kind of a little bit more force than doing coached pushing, which means like, oh, let's push and hold for 10 seconds. I don't think that pushing, holding your breath is bad, particularly with an epidural. I just think we need to teach people how to do it effectively. And so when I see people in my clinic, I have many, many patients who are going to get an epidural as well. Obviously, I tell them to kind of wait as long as they can, comfortably, typically till they're like, 5, 6, 7 centimeters, because they're going to be further along in their progress before they are immobile in bed. I tell them to, and during my physical therapy sessions, I teach them to push in different positions. Some people push really well lying on their back. Some people push better lying on their side. And both of those positions can be effective and utilized with an epidural. And I don't think that often people think that like, oh my gosh, I'm not going to be able to get on my side. Like talk to your medical provider beforehand and say like, hey, I'm going through therapy. I practice pushing. I feel like I could do it better on my side. Or you can push on your side and right when baby's about to birth, you roll into your back or you get into stirrup. So trying different positions, also trying it exhaling, practice holding your breath, and then also practice breathing. So which one is better for you? And I actually teach people to do this while they're pooping. So I'm like, if I see you at 36 weeks of pregnancy and we practice pushing, I'm like, every time you poop is you're relaxing your pelvic floor. So I want you to go sit on the toilet. You can kind of bear down, breathe, grunt, moo, blow through a straw, whatever you want to do, and work on that relaxation as practice prior to giving birth, so that the first time you do it is not when you're in the delivery room. We also do it with a mirror so people can see that feedback. Sometimes I have people, I practice in the clinic putting my hand on the perineum to give them something to push against. Sometimes that tactile cue can be really helpful. And then if you have to push holding your breath, that's totally fine. Some people absolutely find that more effective, but I want you to just make sure that you're relaxing completely. You maybe try shifting on your side, putting a pillow under a hip, using the mirror, using the tactile cues, whatever you need to do to make those things effective. But you do need to keep the epidural low. I mean, it's just really hard for people to feel paralyzed and then to know what to do. And then this is what can happen. So, it's just such a tricky thing with medicine now. Like, how do we help people? How do we teach people how to do this, but also do it with medicine? And it's, I do think that there's a way. I just think that we need to be consistent across our medical providers, because I think I'm coaching people how to do it a certain way. And then when they get to the delivery room, a nurse is like screaming at them to hold their breath. And they're like, but that doesn't feel right. I think we just want to give people options and for them to use the options that they are most comfortable with in the moment, versus saying like, you have to hold your breath or you have to breathe. We need to teach them all the ways and then help them work with what their body feels like is most effective for them.
Yes, absolutely. And you guys listening, these need to be things that are on your birth plan. Your birth plan needs to be submitted way in advance by 34 or 36 weeks gestation. You need to print these preferences, bring them to your provider. The time to talk about how you're going to push and how you're going to breathe is not in the delivery room. We're going to reiterate those things to whichever nurse you have or whichever provider's on call, but these are things that you need to be having proactive conversations on. And if you're getting resistance, you're with the wrong provider. And you need to either educate your provider or you need to switch practices. Regarding the epidural, it is okay to turn your epidural off when you get to the pushing phase. So great, you used your epidural, you got comfortable, you relaxed. It's okay to turn it off for pushing. And I have seen less tearing when we do get that feeling back and we turn the epidural down or off. It's so simple. You just have to call anesthesia and say, we're getting ready to push. I can't really feel a lot. Could you turn this down or could you turn it off? And don't be afraid to do that. So
yeah. And one thing I will say is I get a doula. I mean, I know it's a privilege in a lot of places, but I also see it as an investment. And I mean, for me, I was like, okay, I'm going to pay an anesthesiologist or I'm going to pay a doula. And I think I'm a data nerd, and the data is very clear on the birth outcomes that are more positive when you have a doula in place, and just feeling more supported, and just, you're not, it's not all on you to know exactly what to do in that moment. And I think that that's why doulas are so key and so important. And I'm just a huge, huge advocate for them and for the work that you do, Heidi.
yeah. And Sara, same to you in pelvic floor therapy. You guys, thanks for being here today and listening to Dr. Sara Reardon, the Vagina Whisperer, talking about her new book, Floored. Please go to the show notes and pre-order it if you're listening before June 10th. And if it's after June 10th, go ahead and snag that copy. It will be on your doorstep within a couple of days. I appreciate you being here. And you guys, if you get the book, you will learn that Sara is maybe planning Running of the Vulvas, where we all dress up as vulvas and we go for a run in New Orleans. I will be there if you do it, Sara. Okay.
This is true. Thanks so much. Stay tuned, everybody.
Stay tuned. Have a great day, Sara. Thank you.
Thank you.
Thank you for listening to Birth Story. My goal is you will walk away from each episode with a clear picture of how labor and delivery might go, and that you will feel empowered by the end of your pregnancy to speak up, plan and prepare for the birth you want, no matter what that looks like. And I am replaying an episode that we recorded a couple of months ago, all about the pelvic floor. So congrats, Sara. I'm cheering you on. So congrats, Sara. I am cheering you on, and I wish you abundant success with your book, Floored.